For those of you who may not be familiar with Feeding Community Health, this is a joint program that we run with AllergyStrong and Wendy's organization, FOODiversity. Both AllergyStrong and FOODiversity are nonprofit organizations that work nationally to combat health inequity in the food allergy space. We deal with both nutrition as well as protections for people with food allergies across the country. So again, welcome. And Feeding Community Health strives as a program to bring together communities and strengthen communities by giving information and solutions-driven education. So this is one of those things that we're doing today. Dr. Kim is with us, and we're so lucky. Dr. Kim is the Chief of Pediatric Allergy and Immunology at UNC Health. He is also the director of the Food Allergy Initiative at UNC's School of Medicine and was one of the investigators of the OUtMATCH trial, which dealt with omalizumab, and he'll explain all of that later, and the findings of which were published in the New England Journal of Medicine. So again, without further ado, I'm just going to let Dr. Edwin Kim take it away, and then we are going to get to questions in just a couple minutes. So if you have some questions, please add them to the chat, and we will add them to our list of questions. So thanks for everyone who's already submitted some, because they've been excellent so far. All right. Thanks, everyone. Go ahead, Edwin.
Great. Yeah. So thanks, everyone, for having me. And thank you very much for the introduction. And I'll just start out by just saying, I think, I was really excited to do this just because I think all of us have the same questions. I mean, I think this is the big, really huge news for the food allergy field. And now it's sort of up to us to figure out sort of how do we put this into real practice? Like, what does this actually mean for patients and for providers? And so I'll start out with just a handful of slides just to kind of review kind of the data and start and prompt some of the questions. And some of these slides may start to answer some of the questions. They may raise some new questions, but the whole point of this is going to be the bulk of the time is going to be to try to address the direct questions you have. So I'm going to start with those slides. Let me grab that. All right. And Erin, do you mind? Can you see this? Can you give me a thumbs up?
Yes, I can.
Perfect. Yep. Okay. Oh, perfect. So let's get right into it. So we have a second FDA-approved treatment option. And so I think everyone on the call, I'm sure, is aware, but just to make sure you all know, there is the first approved treatment for any food allergy was Palforzia, which is the peanut oral immunotherapy treatment, specifically only for peanut allergy. And now we have Xolair, which you can see the date on here, hot off the presses. So February 16th is when the FDA officially approved this medication. So now we're the last couple of days of May, so about 3 months into this new medication. And so let's go into the OUtMATCH trial that Erin had mentioned before. So this is the big phase 3 study that ultimately led to that FDA approval of the medication. And so I wanted to just go over some of the basics of this. Now, this is not meant to be super scientific, but just enough information so that we kind of are all talking about the same thing. And so first of all, this is a study that was only done in the US and across 10 different sites in the US. So these are 7 centers that are part of the group called COFAR, or Consortium for Food Allergy Research, and then 3 additional, and mostly representative of the broad United States. So as far west as Stanford and California, and then a bunch on the East Coast as well. Important to know is for this trial, like from our point of view as one of our sites, 177 patients felt like a lot. But when you think about clinical trials for other diseases, usually you're talking about thousands to tens of thousands of patients. So I do think it's important to keep in mind how many patients were seen for this particular study. The way that the treatment worked out was 2 patients got Xolair for every 1 that got placebo. So 118 patients were actually on the treatment itself. 59 of them got placebo, so a fake medicine. And so for this treatment itself, for this study, there would be some of the criteria to get in, and this is going to be important for all of us. You had to be between ages 1 and 55, and then you had to be allergic to at least 3 foods. So one of those foods had to be peanut, and then you had to be allergic to at least 2 of the other foods that are listed over here. And so cashew, egg, milk, walnut, hazelnut, and wheat. You could have other allergies that aren't on the list, but they wouldn't be part of the study. But you had to be allergic to at least 3 of those foods. All right. And then more specifically, to actually enter into the clinical trial itself, you had to have a positive skin test. And so again, most of you all are probably familiar on this call, but skin testing is the main tool that allergists have to help diagnose all kinds of allergies, including food allergy. And so they had to have at least a 4 millimeter size bump on the skin test. And then they also had to have the blood test IgE level for that food that was at least 6 or greater. So for example, for peanut, they had to have a peanut skin test 4 millimeters or bigger and a peanut IgE level of 6 and greater. And that was just to sort of kind of get in the door. But then to actually qualify for the study, they actually had to have a food challenge and show that, first of all, that they're allergic. So they had to have a reaction. And then second, that was a means of trying to establish kind of what is that person's threshold before they ever get treatment so that they can try to show a pre and post that the medicine actually does something. And here again, I think it's important to kind of point out that there are differences in how the foods were considered in the study. And so for the patients, again, these are people that have had a history of having problems with peanut and other foods, have a skin and a blood test. But then on food challenge, to enter the study, they had to react to a dose of peanut 100 milligrams or less. So what in the world does that mean? That's about 1/3 of one peanut or less. So lots of people can be still allergic, but cashew, the other foods, their threshold to get in was a little bit higher. So just again, important to keep in mind that for this particular study, people could be allergic, but if they had a higher threshold, weren't actually studied in here. And so just again, I'll come back to some of those points. So now this is an important table for folks if you've not seen this before. So Xolair is typically dosed by weight as well as how much IgE, how much of that allergic antibody that patient actually has on a blood test. And there is a table that's been created in the past for asthma. So specific for food allergy, they actually created a new table that you see here. And a couple of the reasons. Number one, the reason is because this age goes all the way down to age 1, whereas it's not been approved less than age 5 for other diseases. So we have patients that are going to be at much lower weights. So you see over here in kilograms, some of these younger kids would fall sort of in this range. And then we also know for food allergy that patients can have really, really high IgE sometimes, especially if they have other diseases like eczema. So they were able to study up to higher IgE levels as well than you typically see for asthma. And so this table was created for this particular study. But a point that I'm going to come back to later that I think is important to look at is when you look at the doses, these gray boxes here, these are going to be doses that are given every 4 weeks. These white ones here are going to be doses given every 2 weeks. And so this is an important consideration. And then each, at least with the old dosing, each injection, each needle itself could give as much as 150 milligrams. And so what that means on this table is you could be as small as having half of a dose every 4 weeks, or you could be as high if you were in this range over here where the arrow is, you could be as high as getting 4 injections every 2 weeks. So again, really important to keep in mind because again, the study is about the actual efficacy, but now we're talking about real world and will people do this? Who's the right person for it? In this particular study, the patients were then treated for 4 months, and then they came back and had that food challenge again to show did it work or not. So here, what you see is I'm just going to point the arrow at this left side. So this is specifically looking at peanut. So although we studied all the foods, peanut was the main thing that we wanted to make sure does it work for peanut, and then for the other foods we looked at second. And basically what we saw was 67% of the patients who were getting Xolair. Across all the different foods except for cashew, what you'll see is about 65 to 70% of the patients were considered what we call a responder for the trial. So what in the world does a responder actually mean? And so I put down at the bottom kind of how we tried to define that. And so for peanut, remember, they had to react at 100 or less to get into the trial. And so they had to at least get to 600 or higher to be considered a responder and to actually be in this yellow bar here. For the other foods, they started at a higher threshold. So they had to be 300 or lower. And then they had to reach 1,000 on the food challenge to be a responder as well. And so just again, kind of important to keep in mind of what we're talking about as far as, because when you look at 67%, you know, again, what does that mean? Or 41%, what does that mean? And so that's kind of what it's talking about is people who reach that bar. But again, in clinic, I think that's a question of like, again, why does that even matter? What's this milligram thing? And especially for cashew, 41%. So does that mean 60% of people didn't get any better? And so I do want to jump to the next slide. And so, so first of all, again, to get into the study, you had to be allergic to 3 foods. And so that previous slide was just showing each individual food. But if you were allergic to all 3 foods, what was the chances that all 3 of them got better? versus just 2 or even 1 food. And that's what this slide is trying to show us. And so first of all, what we're looking at is percent better. And so for people who were at least 69% of patients reached that threshold, at 600 milligrams to at least 2 foods. And then if you look at all 3 foods they're allergic to, that number drops to 47%. And so I think the way I would try to explain that to patients is that it's not that every food is not exactly the same across the way. So essentially, the main point I wanted to make from that slide is going to be, for the study itself, they made this artificial cutoff just to be able to say, did someone get better or not for the FDA and for clinical trial purposes. But when you actually look at all comers, everybody came in, pretty much every single patient got better than when they started. There's a handful of people that not even a handful, less than a handful of people that more or less were exactly the same as when they started, but almost everybody got better than when they started. But about 65 to 70% of them got a lot better and met that threshold. So I do think that that's an important consideration for folks when they're thinking about getting on this potential medicine itself. Now, the product label itself, let me, actually, I do want to show the product label if I can again. So this is the product label. So when you're talking to your doctor about, do I qualify or not qualify, this is what they're looking at. What the product label says is it's extremely flexible. So basically all it says is you have to be allergic to 1 or more foods and age 1 and older, and that's it. So there's no IgE criteria. It doesn't say what food, nothing else. And so from a provider point of view, that's actually really nice. It's very, very flexible. So as the provider, as the allergist, we can, if someone in front of us is, we're seeing in clinic is allergic, based on the criteria that we see, then we feel like then they could potentially be on the Xolair medicine. Now, the problem, though, that we're running into at the moment is that insurance companies are trying to figure out what to do with this. And asking around to other folks, what they've told me is that this is very, very common with any new drug. So when a new drug comes out, there is a certain indication that the FDA says yes for, and then the insurance companies then go back to sort of their group and try to figure out sort of what makes sense and come up with their criteria that sometimes directly lines up with the product label, but sometimes could be slightly different. And that's sort of the world that we're living in right now of we as providers have lots of patients who we think would qualify and would be interested in this medicine, and insurance companies for the moment are not quite letting it go through yet. Some of it is just because they're trying to figure out sort of what their parameters are going to be. So there's some insurance companies that have just said no to everybody, and it's not a permanent no, it's just a no until they figure it out. Others, though, have been problematic where they actually have created criteria, and the criteria are very restrictive. So one insurance company that my understanding is they may have pulled back on it now, but there's one insurance company that basically created the criteria of the study itself. And what they said was patients had to have IgE levels and skin test levels that were positive, just like in the trial. They had to be allergic to at least 3 foods, just like in the trial, and they had to have food challenges to all 3 foods. And that basically cuts down the number of people eligible to like 0. And so that can't last. And so my understanding is I think they've already pulled back on that, but if not, I can promise you allergists and patients and patient advocacy groups and the company are all fighting this because, what's the point of doing all this if you're not going to let anyone get on that medicine? And so to summarize sort of the study and then to start the questions, really what we found is that this Xolair, the way it works is it gets rid of IgE, whether it's for food, whether it's for pollen, whether it's for multiple foods. And sure enough, what the study showed was, yeah, across all those different foods, we see that thresholds increase. About 70% of people reached the higher threshold that they looked for in the study, but almost everybody in the study got at least better than when they started. And so a lot of questions are out there right now. Primary questions that come to me right now are who's eligible or who's the right patient for it. So I guess technically, according to the label, almost everybody with food allergy is eligible, but not everyone is sort of the quote unquote best patient. So who might be the best patient for this type of treatment? Important questions are, how do we know it's working? Should we be doing food challenges? Should we be doing lab tests? Like once you start the medicine, like, do you stay on it forever? How do you know it's working? And then a big one that's come up a lot is going to be, do you just do this Xolair medicine, or is it make sense to do Xolair plus something else like an oral immunotherapy or something else like that? And so those are questions that we're all grappling with, and I have some opinions on some of those. But I don't know, Erin, if you wanted to just start with certain questions and then we can kind of go.
We have a lot of questions about safety, and I'd love to start with that right there. So we talked about the approved ages. So this is safe for, I mean, a lot of people want to start their young infants or toddlers on this. Can you talk to us about what that looks like in young children?
Yes, absolutely. So I think one reason that allergists are really excited about Xolair is that it's not new. And so Xolair first was approved for asthma about 20 years ago, and then it got approved for chronic hives about 10 years ago. And so we have lots and lots of data on safety, and allergists are very comfortable with sort of what side effects to look for. Now, given we haven't looked at it less than age 5, and so there is a question of between age 1 and 5, is there something new or something else that can pop up? But at the moment now, that's not something that we've been worried about. So the first thing I would say is different than oral immunotherapy and sublingual. Xolair, we're not giving what you're allergic to. We're not exposing the kids or the adults to the food itself. So there shouldn't be a risk of sort of food allergic reactions or anaphylaxis like you worry about with OIT. Theoretically, there is a chance that you could be allergic to the medicine itself. And so the way that it's prescribed right now is the first 3 doses are typically done in the clinic to just make sure that nothing like that happens. And then once that is clear, patients are allowed to start administering at home if they're comfortable doing that. The most common side effect we saw in the study and what's been seen across all studies has been just redness and pain at the injection site. And that's, again, you would expect with any kind of shot out there. There are a couple of black box warnings that have been on the Xolair label since the days of asthma. So one of them is a potential increase of cancer, and multiple studies since then have proven that that just doesn't seem to be a concern.
Right.
Recently, there was a concern of cardiovascular increased sort of heart problems in maybe adults with this as well. Again, not one of those that's been proven in a lot of patients and just not been a restriction that any allergists have really been concerned about. And so again, at least from my point of view, this is one of the safest medicines. From an immune system point of view, I have gotten questions of, does this suppress your immune system? Are you going to be at risk of COVID or the flu or other stuff? And again, a reason we like this medicine is it very specifically knocks out the allergic antibody that's called IgE, but the infection fighting antibodies, IgG and IgM and IgA, are not touched at all. And so patients on this medicine would be able to fight off those kind of infections exactly the same as whether they're on the medicine or not.
That's terrific. You've answered like 3 or 4 questions in this one answer. Can I ask you also the effectiveness for people who are over 18? A lot of times we see the studies that go up to age 17. What does that look like for adults?
Great, yeah, and some of that question may be coming from, we know for oral immunotherapy, sublingual, and epicutaneous immunotherapy that it seems like the younger you start, the better. And some older teenagers and adults maybe get very little benefit from it. When it comes to the Xolair medicine, at least from the study, unfortunately, we only had a couple of people that were above 18. The FDA still felt very comfortable with how the medicine works in the data to approve it for basically all ages. And so we kind of have to extrapolate what the efficacy would be for older. I will say within the 1 to 18 range, the 18 did just as good as the age 1. And then when we look at the other diseases that it's approved for, so urticaria, so the hives, as well as the asthma, it works just as well in the older population. So adults, older adults, young adults, teenagers, as it does for kids. So every indication to us is that it should work just as well in teenagers and older.
That's wonderful. And then can you address any of the long-term effects of the use? And also maybe at the same time talk about how long can you take this medicine? Maybe there's sort of 2 sides of the same question.
Yep. Yeah. And so there is concern. So like some people wonder, why in the world do we even have IgE? Like, why does our body have this stuff that just causes allergy? What's the point? And so one of the things that it does do from an immune point of view is it can be one part that helps to fight off parasites. And then we're lucky in the United States and a lot of other sort of developed countries, parasites just aren't a real, like an everyday problem at all. And so there's some thoughts, well, if you're on this medicine for super duper long periods of time, could you be at risk for that? But again, we've used this for 20 years now in patients with asthma and just have not seen that. And even patients who go travel to third world countries and stuff like that, they're not coming back with all sorts of parasitic infections. So our impression is that other parts of the immune system can just step in and take over for that. And so really at this point, we've not had sort of long-term concerns that we've seen from this medicine, at least from 20 years of experience. And then how long can you be on it? I mean, again, the same answer to that. Theoretically, if your disease was a problem that you wanted to stay on it for years and years and years, right now, we think you could.
That's wonderful. That's very helpful. So since a lot of our community experiences more than one allergic disease, they might experience asthma or seasonal allergies. How does Xolair affect those conditions?
Yeah, so that's to me one of the biggest selling points of this medicine versus everything else that's out there is that um, again, it goes back, it takes out that IgE and it doesn't care if it's IgE to peanut or if it's to shellfish or if it's to ragweed or if it's to penicillin or any other stuff. And so it's a medicine that has the potential to help all your allergic diseases all at once. And so if you happen to be allergic to multiple foods, but also have seasonal allergies and then have allergic asthma, it can definitely help there. The asthma to me is the big one because, again, many of you on the call probably know that we know that having that sort of scary, life-threatening, life-ending reaction is exquisitely rare. When it does happen, though, it does seem like one of the risk factors for that is going to be someone who has asthma that's really poorly controlled or hard to control. And so to have a medicine that not only protects you from the food allergy point of view, but also can get your asthma under control, to me seems like sort of a double protection in a way against that really scary thing that we're all, again, we know it's rare, but it's hard not to think about that. And so I do think that is, if we're going to start talking about the perfect patient, that might be the one that has multiple food allergies, but also has asthma that's been tough to control.
That's a really good point. And is there an overall IgE level or an ideal range that makes someone a better candidate than another? Is there a range that's either too high or too low?
Yeah, so I think that's a piece that we're trying to sort out because at least their first pass through the data gave us an opposite answer because, in our minds, okay, the medicine goes in, knocks out your IgE, that number goes low and then you're better. So it would make sense that if you start low, that's got to be a good thing. And strangely in the data right now, there's a hint that maybe starting higher is actually better for you, which just doesn't make sense. And so right now they're digging through the data to try to understand, is this real? Is there a scientific reason we can explain this? Or is it just based on who came into the study? And, we did have an artificial cap, like you had to be on that table in order to actually get into the study. So that's a part that we don't know. But I will say anyone sort of within that range, we would expect to have a benefit.
That's great. That's great. And I know that there are different methods for using for administering this medication. Typically, it's through an auto-injector, correct?
Yes.
Is there also a syringe method, and is there one that's preferable to another for any type of person?
Yeah, great. It's a great question. And so they have these pre-filled syringes, as well as, again, you can just draw it up in a syringe needle and give it as well. The drawn up in a syringe needle would not be something you could do at home, though. So for families and patients who want to do it self-administered, they would get that auto injector kind of self one. If you happen to get it in your clinic, though, they may have access to both. But I will say that the company is, pretty aggressively been trying to move to these auto injectors just to have sort of one source of it. And it kind of makes sense to me.
That makes sense too. Okay. Well, so moving on to sort of the side effects of Xolair. I mean, is there anything that you've personally seen, anything that's like common, maybe even just after injection or after long-term use, things that we should look out for?
Yeah. So again, back to safety, and I've not, and I've used this for many, many years, and not for food allergies specifically, for people who have recurring hives and asthma, and I've just not seen anything as far as real side effects, and that's why I'm so excited for this medicine. Just knowing that, because we know OIT works, but it's so hard to do, and then there are so many side effects that just limits who can actually do it. So this is a medicine that just seems to have very, very, very few side effects. The main one, it's a real one, it's a big one, is the fact that it's injections and you can get pain and redness and all that at the injection site. And one injection, maybe 2, 3, 4 injections, it's a lot. It's asking a lot. So I think to me, that's the main limiting factor here. I do want to bring up one other point that I think is also really important is, we're somewhat spoiled here in sort of North Carolina, in Charlotte area, and then the RTP area, that there are a good number of allergists out there and ones that are doing food allergy stuff. But there are lots of parts of the country that just don't, or lots of parts of North Carolina, but lots of parts of the country that don't have allergists or don't have OIT and stuff like that. And so every allergist in the country right now probably uses Xolair. And so from an access point of view, I think that's really important. It's not, you don't just have to go to a food allergy center to get Xolair for food allergy. But if you wanted to get those other treatments like sublingual, oral, or epicutaneous, likely you have to go to a food allergy center.
That's a really good point. I mean, jumping sort of piggybacking on that point, what do you recommend for people who do not live near an allergist or don't have one just in their area, you know, whether it's a rural setting or even in other, you know, suburban, urban settings, sometimes there's not an allergist available.
Yeah.
You work with a PCP to get Xolair, is that a possibility? Or a pediatrician?
Yeah, so I think that this is a tricky area right now is, I mean, again, there's going to be PCPs that are going to be very comfortable sort of administering Xolair and sort of observing and all that kind of business. I think that the only hesitation there is making sure that the actual diagnosis is correct. I think that part is tricky. And there's going to be some PCPs that do a lot of food allergy and are going to be very nuanced and good at that. There can be others that are not. And unfortunately, we know that our blood testing right now is you know, medium at best. I mean, there's a high risk of false positives with just depending on the blood testing right now. So that's the only danger that I think you run into in those scenarios. But with the proper diagnosis, I absolutely think that PCPs would be, you know, again, qualified to be able to do that. And so, you know, what does that look like in the future? Is it that you get some sort of remote sort of visit with an allergist to get that diagnosis? Or maybe you do make the long drive just for that one visit to confirm the allergy, and then your primary helps you with the medicine. That might be a strategy as well.
Thank you. That's great. That's really helpful. Okay, moving on to effectiveness. How long does it take for Xolair to reach its, you know, most protectiveness, essentially?
Yeah, great point there. And so I think an important piece there is going to be the study I mentioned earlier. They did treat it for 4 months. And so that's what we know. So that efficacy data is based on 4 months of treatment. I will extrapolate back to what we see for hives and for asthma. And so typically what we see there is the majority of patients who are going to get better on the medicine get better in the first month. But you do have some people that take 2 or 3 or 4 months to start to get better. And so from a food allergy point of view, again, I would tell folks to probably expect 4 months, although again, in my mind, I know that many probably are starting to get better even after the first injection.
That's really great. That's very encouraging, actually. And then how does someone know if the medicine's working? So, you know,
Yes.
how do you test effectiveness essentially or efficacy? Is there a way to evaluate it that's non-invasive, or do we rely on food challenges, low dose food challenges?
Yep. So this is the part that probably is the number one biggest question for food allergy right now is this piece. And so so the way that Xolair works is that goes into your bloodstream and it removes that IgE antibody. But just removing the IgE antibody doesn't necessarily equate into actually being sort of desensitized or tolerant. And similar, like if your IgE doesn't go all the way down to 0, you could still be desensitized and less reactive. And so checking blood tests once you're on a medicine typically has not been helpful. And then skin tests are trying to also show us IgE. So skin tests probably also are not going to be reliable. If they're getting smaller, that's a good sign, but it's not strong enough to be able to, for us to confidently say, oh, your threshold is 1,000 or 2,000, or we wouldn't be able to say that, just that, hey, it looks like the medicine's getting in there and doing something. So right now, at the moment, food challenges are probably the only sort of reliable way we have to try to say someone is getting better. But food challenges are really hard, right? So if anyone on the call has been through a food challenge, you know that there's a risk that, you know, we're intentionally giving what you're allergic to, so you could have allergic reactions. It typically takes multiple hours. Not every office offers it. And so, again, we need something better. But right now, until we come up with that better, is there a better blood test, skin test, something else that we can use? It's right now we're saying it's probably food challenges. Right. What we're thinking about at UNC and a lot of other places is exactly what you just mentioned, Aaron, whether you did it on purpose or not, was this concept of low dose food challenges. So not necessarily like, so say we wanted to check someone who's on Xolair and, hey, are you better with cashew? As opposed to giving cashew until you get sick, because that's what we sometimes would do, is try to figure out how high can we go. Instead of that, maybe more like, okay, maybe we can get 1 or 2 cashews in there just to prove to ourselves that it's doing something, and then that there's like a real kind of level of protection that's out there, but not, again, push the limits. And that would be good enough. And sort of this idea of sort of a low or medium dose that we would do. And so that's definitely the direction that we're thinking about going. Our thoughts here at UNC are, you know, probably give it a good 6 months on treatment, and then offer that as an option. Now, again, plenty of patients are going to say, look, I'm on this medicine because I don't want to go through reactions. I don't want to do all this stuff. Perfect. Again, I'm good with that. But there are going to be some patients saying, well, these are a lot of shots, or hey, I'm paying a lot of money. I kind of want to know, is this working? And so that would be a reason. And then another area that, we are starting to talk about also is for the patients who don't want to do this forever. Some have talked about, well, could I use this medicine and then switch to the food as a way to kind of maintain that protection? Could I do Xolair for 12 months and then switch to eating one peanut a day or something like that? Or, a tiny sip of milk every day. Is that something that we could do? We don't necessarily know the answer to that, but the only way we would ever get there is probably right now a food challenge.
Okay.
Prove that you can eat a little bit, and then, yeah, maybe you can transition to that and see what happens.
That's great. That's a wonderful answer, and it gives us a lot of encouragement. Does Xolair continue to offer protection after you stop using it, and for how long, if it does?
Yeah, great question there. And so unfortunately, the answer for this one is no. And so the way the medicine works is it takes out the antibody, but it doesn't take out the cells that make the antibody. And so once you stop the medicine, we expect probably within 6 to 8 weeks that those cells are starting to make more of that antibody. And so that reactivity may start coming back. How long before you're fully reactive again, back to where you were before, that kind of stuff we don't necessarily know right now. But I think the simpler answer for this is going to be you really need to stay on the medicine to stay protected.
Stay protected. That makes sense. And then you sort of addressed this, but people wanted to know sort of what happens to IgE levels on this medication, what happens to mast cells on this medication. Is there anything else you sort of want to talk about with what specifically happens there?
Yep. Yeah. So again, the IgE levels should go down, but it can take a little bit of time for that to go down. So if I check the levels within a couple of weeks, it might not be any different. It might even be higher because of the way the medicine works. After 4, 5, 6 months, I'd expect the total IgE as well as the IgE to the specific foods to be lower. It could be all the way down to like 0, or it could be just be lower than it started. And again, that's where we don't have sort of that level of kind of accuracy just yet for those levels.
That makes perfect sense. And then a big question that we get a lot is, when someone takes this medication, will they be able to eat their allergen essentially? What does that look like? Or is this more a level of protectiveness against accidental exposure?
Yeah, so the intent of this right now is protection against accidental exposure. So try to continue doing the same level of avoidance that you've been doing, but to protect against that what if, and across all those foods. So that's really the intent of the medicine right now. One part of the OUtMATCH study that's actually still ongoing is we are trying to see if we can transition people not to tiny bits of food, but to a good amount of food. So trying to answer the question that you just asked.
Right.
And so we'll hopefully start to see some of that information later this year about how effective is it. The problem though with that part, so we definitely know we're not going to get to a point where people can eat just unlimited amounts of food. That we know we can't get to, but we do think that there is a potential for some people to be able to introduce like real amounts of food. So half a glass of milk, or a bite of a peanut butter cracker, or again certain real amounts. But again, this goes back to the food challenge. Really, that's what we're going to need to do that to really get a sense of where that threshold is. And then, I think the other point that I would bring up is once we go back into that world, if we stop the Xolair, then even though you're eating the food, a lot of the side effects that you might expect from OIT, so allergic reactions, stomach pain, vomiting, even this disease called eosinophilic esophagitis, all of these things come back on the radar because by eating the food, more or less, you're doing a form of OIT.
That's true. That's true. And would it be possible in theory, assuming this is an individual with your allergist kind of decision, but to eat cross-contaminated foods, things that are in a may contain label, under a may contain label? We call these precautionary labels, but
Yep.
Is that potentially an option?
Yeah, I mean, I would absolutely think so. I mean, many people can eat foods with those precautionary labels right off the bat,
Right. Yeah.
just because we know that many times there probably isn't a contamination, and even if there is, it's probably a small amount. But I can't sort of tell patients in front of me like 100% for sure, like 99%, but not 100,
Yeah.
just because you don't know, like, especially when you go to smaller companies that don't have as much control over their manufacturing. And so I would absolutely think that this, again, based on the numbers that we saw, like these are people that are getting, 10 times their baseline threshold in protection. So I would think that this is something that would further protect against stuff like that. But even here too, I'm cautioned in the background. I hear the whispering in my ears. I can't tell people 100%, but I mean, I would feel really good that at least those types of things really shouldn't have to worry about.
Yeah.
I do want to answer a quick question that I saw pop up in the chat. Someone had asked about EOE and Xolair. And so, because one question was like the Xolair, can you do Xolair plus OIT or Xolair plus the food? And would the Xolair protect against the side effects of OIT? Unfortunately, what we've seen is it does not protect against EOE, this eosinophilic or these GI stomach problems that people have when eating the actual food itself. It may reduce the chance of anaphylaxis when you're eating the food or OIT. But as far as protecting against those GI side effects, we've just not seen that.
So kind of related to the EOE question, it's not related, unrelated, but in terms of other conditions that people experience in this community, what about Xolair and alpha-gal? How do those interplay, or do they?
Yeah, so we do think of alpha-gal as being a disease that comes from IgE. It's different. It has some differences, of course, like it's to multiple meats. It's specific to a sugar, not a protein, things along those lines. But at the end of the day, it's an IgE disease. And so we do think that Xolair should be able to help there. We don't have the studies. There's small reports that people have done, including some folks here at UNC, that seem to suggest it would work. But I would say just from a pure science bio point of view, I would fully expect it to be helpful.
Do we think we'll see studies on that in the future?
Oh yeah.
Right. Okay, good. Because that's a growing.
People love their meat.
Good, exactly. People love meat, and alpha-gal is growing, so it's a growing problem in this country. So it's important to know if there's a treatment out there to help them. That would be to help patients that have it. That'd be amazing.
Yes, yes.
Yes, people do love their meat. Okay, so moving on to sort of food allergy management type questions. So how can an allergist evaluate someone's food allergies, like their IgE numbers, if their patient is on Xolair? So in other words, let's say you are starting to react to maybe something new, or you're having breakthrough reactions. How do you evaluate? What does the skin prick test or the blood test look like when you're already on Xolair?
Yeah, so this another great point here that we're trying to figure out. And so once you're on the medicine, like I mentioned before, we can't interpret the skin and the blood test the same way. And so first of all, for new allergies that may pop up, we won't be able to figure that out based on skin and blood tests. Unfortunately, you again would probably have to rely on a food challenge. And then if you're on the medicine, I'd like to think that it's protecting you. So can you figure out, is that food caused it? So I'm going to just make up, like, say, kumquat. So I just had kumquat for the first time, and then I felt really sick. And is it from kumquat? And again, the IgE and the skin test would be messed up because of the medicine. And even if I did a food challenge and I passed it, is it because I'm on the medicine or is it not?
Right.
And so, and then I do want to take this to a different direction of the same question comes up for foods that you outgrow. So how about a kid who's on it for milk and egg allergy? We know that 80% of kids outgrow milk and egg. But we typically use the skin and blood test to kind of tell us that we're probably there. And so on this medicine, how do you know? And so that's also, again, a question we don't have an answer to at the moment. And so what would end up happening is going to be probably a conversation between me as the allergist and the family to say, well, based on kind of what we've seen as far as exposures and time and things, like, it might be a good time to find out. And we'd really have to stop the Xolair, and probably for a few months, and then try to do a food challenge. So complicated. And some families may decide not to even start it in the first place because they don't want to sort of muddy the waters there. So I think that's a tricky situation that definitely will take a lot of discussion sort of upfront before ever starting.
That makes a lot of sense. What about Xolair and athletes? Does Xolair interfere with like a daily athletic routine? How does it impact training or even exercise-induced asthma? I know those are three maybe slightly different questions, but does it have an impact on people who are, incredibly active to that level?
Yeah, so again, great news here is that Xolair has exercise has no effect on Xolair working better or worse. Xolair works the same.
Rest times, essentially, yeah.
And I think that's going to be the most important point here. And I'm guessing this question may be coming because of, we know with the oral immunotherapy, again, when you're intentionally eating the food you're allergic to, when you exercise vigorously, we know that increases the chance you can get sick from the food itself. And so there's all these restrictions around how much exercise you can do when you're on OIT. None of those are the case for Xolair. So you are just as active as you ever were. And yeah, really, there's no restrictions at all. And if anything, again, it helps your asthma. And so for those kind of aerobic type sports, if you happen to have asthma, they may actually help you.
Even exercise-induced asthma. That's
It could.
that's
If
really
there's an allergic component to it, it could, yeah.
that's really terrific news. Does Xolair affect bone density or fractures of any kind? Does it have any impact on your, this bone strength essentially?
Yeah, so that's not something that we've seen.
Great.
And the way it works, it's not something that I would anticipate seeing a problem with.
That's awesome. And someone asked if you could begin Xolair injections if you had something like a sinus infection or a cold, or, just happen to be, you can't predict when you begin these things, whether you'll, get any number of little things in the air. Can you be sick, essentially have a virus and start Xolair, or do you need to do it under good health?
Yeah, I mean, again, normally I think you're going to want to be in good health, but you don't have to be.
Okay.
And just because I think it's going to be helpful for you as a patient and also for your provider to just get a sense of like, what is like on a regular day, how do you respond to Xolair? And then, again, when you're sick and stuff like that, we can kind of see if things change. But again, keeping in mind, this is a medicine that's given every 2 or 4 weeks. So if you're sick and you just wait a few days and you come at 5 weeks instead of 4 weeks, again, in my mind, no harm done. Probably don't want to go I mentioned earlier that 6 weeks seems to be sort of a magic cutoff where it may be starting to wear off. So, but if you just have to shuffle it by a couple of days, but when you're feeling kind of run down like that, you don't want to be getting someone sticking needles in your arm anyway. So it's probably better to just give it even if it's not increased risk, it's probably just better to give it a couple of days.
Well, it's good to know there's some flexibility as well. So that's
Yes.
helpful on the patient end to know that. That's really helpful. Great. Thank you. And can also, I'm just again thinking of the general population, we all of us use antihistamines quite frequently, especially right now in the spring and summer seasons. Is that something that you can continue using while you're on Xolair? Is there any conflict there?
Nope, no, not at all. Yeah, so absolutely, many of our patients are on antihistamines coming in, start the Xolair, stay on it. The hope would be, again, depending on what they're on the antihistamine for, if it's for seasonal allergies, I mean, if the Xolair works, maybe you don't need to be on it every day. So that could be a benefit there, but definitely no harm in being on both.
Be a huge benefit, actually. I'm sure a lot of us like to go off our daily antihistamines. Okay, so a couple of like medication and treatment questions. So although both are used to treat allergic disease, which is more effective for treating food allergy, Xolair or Dupixent?
Yeah, so at this point, we've not seen a lot of benefit from Dupixent for food allergy. Amazing for eczema, amazing for asthma, but we've not seen it for food allergy. And so at this point, the company, I don't believe they're actually pursuing trying to get approved for food allergy, at least not the medicine the way it is. So I think if food allergy is the main problem, it would definitely be Xolair.
Great. And can Xolair help with eczema? Does it have an effect on eczema?
So not that we've seen. Yeah.
Okay.
So unfortunately, so some people have asked, do you end up on 2 medicines? And
Right,
yes,
that's the next question.
very nuanced as well. That's a lot of injections, and I'm not sure that I would sign up for that. But at the moment, we don't think of Xolair as helping with eczema. And unfortunately, we don't think of Dupixent as helping with food allergy.
Right. So one is good for one and one is good for the other. And can you be on both? I mean, I agree. It would be hard, but if you were willing to tolerate, you could potentially use both medications at the same time.
You could, and there actually is a study out in Stanford that's doing exactly this to see if there's some additive benefit of the 2 of those. But it's tough. And so again, some people I can't see who would sign up, but there may be some reason for it.
Okay.
But it does give me a moment to just add in one other component is, I think a lot of the discussion kind of goes with the idea that, hey, I'm going to start this medicine and be on it for life. And that's not necessarily reality for many patients, if not most patients. And so I will say, even in these first 3 months of talking to patients about it, most of them are thinking about very certain situations. So situations that come up is, oh, I'm about to go study abroad in Europe. And my understanding is they don't label foods quite the same or as well. Is this something that I could use for a semester? I don't see why not. I mean, you just want to start it early enough that we feel confident it's kind of kicked in before you go. I've heard of people, hey, I'm about to go off to college, and it's going to be my first time living on my own in a dorm and eating at the food halls and cooking myself. Yikes, and I don't know that I can do an oral immunotherapy every single day when I'm off in college and, whatever. And so maybe there's a role. So I do think that even in that case of the combo Dupixent and Xolair, I mean, maybe if we're talking about for a set amount of time, some people could sign up for that. But again, not necessarily lifelong, and you may not need to do lifelong.
Yeah, that's a really good point. And I like the examples of the stages at which you might consider this medication. I think that's really helpful to everybody. Can you use this, or can you talk about Xolair being used in combination with OIT, oral immunotherapy?
Yep. Yep. So this question comes up a lot. Interestingly, I think this question comes up more in academic places than in private practice. But I think the main question that I ask families is, what is the outcome that you're looking for?
Yeah.
And to make sure, because basically what by doing that, you're kind of adding two treatments and making treatment much harder. And so it's going to be a lot more work on you guys as the family to be able to do that. And so Xolair by itself looks like it desensitizes, so protects against accidental ingestions. And that's also what OIT does. It does seem like if you start young enough that some patients with OIT might be able to get more of a lasting benefit, but even that's not a cure. So we're calling it remission with the idea that you can actually have a relapse. And so it's not a cure. And so it does seem like OIT maybe gives us slightly higher thresholds, but if we're not necessarily introducing the food and eating it, do you actually need that? And so I think these are some, tough questions that I ask the families and bring this up. What are you looking for? And if the answer is they're just looking for sort of protection against accidental ingestion, there probably isn't a reason to do both. But if you're a family that wants a higher threshold, or if you're a family that wants, likes that idea of maybe I can transition over to the food, then that might make sense too. You start with the combo, then you go to just the OIT, and then you just go to the food. And that might be a sequence that helps you get there as well.
Yeah.
So I think there could be a role for some patients, but again, really important to talk through, what they're looking for in their outcome, because it's not easy. OIT itself is very hard. And then if you add a shot every 2 weeks to it, it just makes it that much harder. So making sure that it's, again, something that makes sense.
No, that's a real practical consideration. Thank you for mentioning it. What about Xolair and allergy shots? A lot of us get allergy shots or just, slit therapy for environmental allergies. Are those two things that are compatible, or is that a little redundant? What does that look like?
Yeah, so it's interesting. So it turns out that Xolair plus allergy shots is something that people have been doing for a while now. And typically for allergy shots, the people who are getting both are the ones that are struggling to build up on their allergy shots, whether because of side effects or because of asthma. And so some people have gone on Xolair to try to just reduce their overall kind of allergic nature so that they can tolerate the allergy shots better. But different than the OIT question that I just mentioned before, we do strongly believe that allergy shots can give you long-term cure or remission from your allergies.
Yeah.
So that's a reason why we do think that there's a reason to do both, because we
Great.
do think that end outcome from the allergy shots for your pollen allergy could be lifelong. Whereas right now for OIT, we're not so convinced about that. So that's where it's less clear if you need it for the combo for food.
That makes perfect sense. All right, so we have some questions about insurance. A lot of our participants are having some problems with insurance. We only have a few minutes, so let's cover them as fast as we can cover them. But essentially, patients are having a hard time getting it covered, and some are having a hard time getting this covered because they might not have a peanut allergy, but they have lots of other allergies, or even just one other allergy. What is recommended in these cases? Is that a restriction of the FDA? Can you explain where this is coming up and why, and what we can do about it?
Yes, so this is I've always been gray, but I'm more gray.
Yeah, I understand.
This has
But as
been
much as you
quite
can.
this has been quite frustrating, and I sort of hit at it before. So again, from the FDA point of view, they have nothing to do with this. So they help make that label that is again super flexible, like I mentioned earlier. So basically, 1 and older allergic to one or multiple foods. They don't even say which foods. So
Right.
from their point of view, it works, and it works across all the foods. Period. So
Good.
it's really purely the insurance companies right now that are trying to come up with a way that they can offer it to enough people, but managing sort of in some way from their point of view, which I don't agree with, but it is what it is. And right now, like I mentioned earlier, the companies seem to be each individually trying to figure out their own criteria at the moment. And so we're right in that sort of limbo air time where it's just so frustrating. From the allergist point of view, again, what we're stuck doing is we're petitioning. So we can do written petitions, and then we can even do phone petitions, something they call a peer-to-peer, where
Yeah.
we speak to the medical the doctor on the insurance company side to kind of argue our case. And when I've done this so far, again, what I'm getting right now is more this idea that they just don't know what their criteria yet or not are at the moment, and so they're kind of kicking the can down the road a little bit. And So I do think that this was going to get better and fix itself, but it's probably going to take a few months. And so for the short term, especially if we have one of these critical needs, hey, I'm about to go abroad, or I'm about to start kindergarten for the first time, like, used to be peanut free and now it's not. These are situations where your doctor can try to fight for it and do what they can. I can't imagine that it's going to ultimately say you have to be allergic to 3 foods and any of that kind of business. And it shouldn't say you have to be allergic to peanut. It should be, like the label says, really allergic to any number of foods is ultimately where it needs to get to. And so we're all fighting for that right now.
That's great. And it's hugely appreciated by patients, because obviously we would love to get the coverage and the protection for ourselves. So
Yeah.
we appreciate the extra work that all the providers are doing on our behalf. So again, thank you. And thank you for that well-rounded answer. And just as a last question, for those of us who may go into a doctor's appointment a little shy or a little reticent to bring this up, what do you have any suggestions on how to approach this, how to, have a productive shared decision-making process? How should we approach this?
Yeah, I mean, I think they're just raising the question. Hey, I've heard about this Xolair medicine. I've read about this Xolair medicine. Can you tell me a little bit more? And if that person's not comfortable, again, can they refer you to someone else? Along those lines. And I think just sometimes allergists get a little bit defensive if you go in and say, I want to be on Xolair 300 milligrams every 2 weeks, and sort of but I think if you just raise the question, I mean, how can you want to do the best you can for your kids and for your family, right? I mean, that's just part of being a parent. That's what we do. And so advocating for our parents, I think absolutely just, perfectly fine to go in and just, start the conversation. Hey, can you tell me a little bit more about this? Is something I think I'd be interested in. And if you don't get the answer you want, it could be that as the allergist, they're also trying to figure things out, because clearly I shared here, these are thoughts that I have right now, but none of these are answers, right? These are all things that we're trying to sort of figure out. How do we interpret this? How do we manage this?
Right.
Some of that kind of stuff. But if you're not quite getting that answer, it may just be that your allergist is not sort of, as up to date on that at the moment. And so either they'll catch up, or you can, look around for second opinions to find folks that might be more familiar.
That's great. That's a great answer. And we appreciate that as well, because it is a new subject for everybody, not just for us as patients, but as you point out, for you guys as providers as well, something to adjust to in some regards. And but it's also really good to know that this medicine has been on the market and been in use for 20 years or more. It's wonderful to know that it's been so safe, that it's been so efficacious for asthma, and that we're seeing such great results for food allergy. I mean, we're all really encouraged and excited about this as an option for the community. And like I said, it's just something to celebrate. And we appreciate your time here immensely. I know that there'll probably be more questions, and I will do my best to maybe even do a follow-up post. Maybe you and I can do an article and I can post those answers. So if anyone has more questions, and I do expect that they will just arise naturally, please feel free to direct message us at Feeding Community Health. And if you have, we're on Instagram, on LinkedIn. So feel free, if you want to just direct message us, that's fine. If you have our emails through both AllergyStrong and FOODiversity, you're also welcome to contact us that way. And we will get this directly to the broader community at large. And I just thank everyone for being here. It was so nice to have you here, Dr. Kim, and to answer all these questions directly, like straight from the investigator. This is such a rare opportunity that we get to just sit here and hammer you with questions that we have. But you have covered so much ground today, and your time is greatly, greatly appreciated. And I really appreciate everyone being here on the call with us. If you have any more questions, and we will be bringing you more programming through Feeding Community Health on topics that interest you. So also please let us know what that looks like. All right. Thank you, everyone. It's so great to talk to you, and I will see everyone soon, hopefully. Bye. Take care.